Neuroscience and mechanisms. A more comprehensive understanding of the nocebo effect requires an in-depth examination of the neural circuits and neurochemical processes that mediate expectation-induced symptom generation. Contemporary neuroscience conceptualizes the nocebo effect as an emergent property of distributed brain networks involved in prediction, salience detection, emotional regulation, and interoceptive processing. Rather than being localized to a single brain region, nocebo responses arise from dynamic interactions among cortical and subcortical structures that collectively shape the perception of bodily states. Central to this process is the anterior cingulate cortex, ACC, a region implicated in both the affective dimension of pain and the regulation of cognitive control. Increased activation of the ACC during nocebo conditions has been consistently observed in neuroimaging studies, suggesting that negative expectations amplify the emotional salience of sensory input. The insular cortex, another key structure, plays a crucial role in interoception, the brain's representation of internal bodily states. Heightened insular activity during nocebo responses indicates an increased awareness and amplification of bodily sensations, which may contribute to symptom perception even in the absence of objective pathology. The prefrontal cortex, PFC, particularly its dorsolateral and ventromedial subdivisions, is involved in the generation and maintenance of expectations. Top-down signals originating from the PFC can modulate activity in lower-level sensory and affective regions, effectively shaping how incoming stimuli are interpreted. In the context of the nocebo effect, maladaptive or negative expectations encoded in prefrontal circuits may bias perception toward threat-related interpretations, thereby enhancing discomfort and distress. In conclusion, the integration of clinical observations, experimental data, and methodological insights provides a comprehensive understanding of the nocebo effect as a genuine and impactful phenomenon. Its presence across multiple domains of health and disease underscores the necessity of incorporating psychological and contextual variables into both research design and clinical decision-making. As the field continues to evolve, future studies will be essential in refining strategies to mitigate nocebo responses while preserving ethical standards and patient autonomy. Another methodological consideration involves the role of informed consent. While ethical standards require that participants be fully informed about potential risks, the act of disclosing these risks can itself induce nocebo responses. Some researchers have proposed alternative approaches, such as authorized concealment, in which participants are informed that certain details about side effects may be withheld to prevent bias, while still maintaining overall transparency. Although controversial, such approaches highlight the ongoing tension between ethical obligations and the minimization of harm in research settings. Individual variability in nocebo responsiveness remains an active area of investigation. Psychological traits, such as neuroticism, catastrophizing, and heightened interoceptive awareness have been associated with increased susceptibility to nocebo effects. Moreover, genetic factors may influence neurotransmitter systems involved in expectation and stress responses, further contributing to individual differences. Understanding these factors is essential for identifying at-risk populations and developing targeted interventions. Importantly, the clinical implications of the nocebo effect extend beyond controlled research environments into everyday medical practice. Misattribution of symptoms to medications, driven by expectation rather than pharmacology, can lead to poor treatment adherence and unnecessary discontinuation of beneficial therapies. This is particularly relevant in chronic conditions, where long-term medication use is required and patient beliefs play a crucial role in treatment success. Addressing nocebo-related concerns through effective communication and patient education is therefore a key component of evidence-based healthcare. In particular, reduced engagement of descending pain modulation pathways suggests that negative expectations may impair the brain's natural ability to regulate nociceptive input. This dual mechanism, enhanced pain facilitation combined with diminished inhibition, offers a comprehensive explanation for the intensity of nocebo responses. In addition to pain-related outcomes, the nocebo effect has been documented in a wide range of physiological systems. Cardiovascular studies have shown that individuals exposed to negative expectations may exhibit increased blood pressure and heart rate variability consistent with stress responses. In respiratory research, participants who believe they are inhaling an irritant may report shortness of breath and demonstrate measurable changes in breathing patterns, even when exposed to clean air. Similarly, dermatological studies have found that suggestions about allergic reactions can induce itching or skin irritation in the absence of any allergen. These findings collectively demonstrate that the nocebo effect is not limited to subjective experiences but can influence multiple organ systems through psychophysiological pathways. Methodologically, the presence of nocebo responses presents a significant challenge for clinical research. Adverse events reported in placebo groups can obscure the true side effect profile of investigational treatments, complicating data interpretation and regulatory evaluation. This has led to increased interest in study designs that account for expectation effects, such as open hidden paradigms, in which the same treatment is administered with or without the participant's awareness. Results from such studies consistently show that awareness and expectation significantly modulate both therapeutic and adverse outcomes, reinforcing the importance of cognitive context in medical interventions. Clinical evidence and experimental findings. A critical aspect of understanding the nocebo effect lies in its manifestation within clinical and experimental contexts, where its influence can be systematically observed and quantified. One of the most compelling lines of evidence comes from randomized controlled trials, in which participants assigned to placebo groups frequently report adverse side effects that mirror those of the active treatment group. These reported symptoms often include headache, fatigue, nausea, dizziness, and gastrointestinal discomfort, despite the absence of any pharmacologically active agent. The consistency of these findings across diverse medical conditions strongly supports the role of expectation and contextual suggestion in generating nocebo responses. For example, in clinical trials involving analgesic medications, participants who are informed about the potential for increased pain as a side effect are significantly more likely to report heightened pain levels, even when receiving an inert substance. This paradoxical increase in pain, sometimes referred to as nocebo hyperalgesia, has been experimentally induced in laboratory settings using controlled pain stimuli, such as heat or pressure. Participants exposed to negative verbal cues consistently demonstrate lower pain thresholds and higher pain ratings compared to those receiving neutral or positive information. These effects are not only reproducible but also modifiable, indicating that expectation is a causal and manipulable factor. Neuroimaging studies provide further insight into the underlying mechanisms of these observations. Functional magnetic resonance imaging, fMRI, and positron emission tomography, PET, have revealed that nocebo-induced hyperalgesia is associated with increased activation in pain-related neural networks, as well as decreased activity in endogenous pain inhibitory systems. Research has shown that framing information in a more neutral or positively balanced way, without withholding essential details, can reduce the likelihood of nocebo responses. This has led to the development of communication strategies aimed at minimizing harm while maintaining informed consent, such as emphasizing the probability of tolerability rather than focusing solely on potential adverse effects. Recent advances in personalized medicine have also begun to incorporate insights from nocebo research. Identifying individuals who are more susceptible to expectation-induced symptoms could allow for tailored interventions that mitigate these effects. Factors such as genetic polymorphisms, baseline anxiety levels, and cognitive styles are being investigated as potential predictors of nocebo responsiveness. This line of research underscores the need for an integrative approach that considers both biological and psychological determinants of health. In summary, the nocebo effect represents a complex and multifaceted interaction between mind and body, mediated by cognitive expectations, learning processes, social influences, and neurobiological mechanisms. Its impact is evident across a wide range of medical and experimental contexts, challenging traditional distinctions between psychological and physiological phenomena. As research in this field continues to evolve, a deeper understanding of the nocebo effect will be essential for improving patient care, refining clinical trials, and advancing our broader comprehension of human perception and health. For instance, if a patient repeatedly experiences side effects after taking a particular medication, the mere act of taking a similar-looking pill, even if inert, may elicit comparable symptoms. This conditioned response can persist over time and may generalize to related contexts, complicating treatment strategies and patient management. Social and environmental factors also play a significant role in shaping nocebo responses. Observational learning, sometimes referred to as social modeling, can lead individuals to develop symptoms after witnessing others experience adverse effects. Media reports, online information, and interpersonal communication can amplify these processes by disseminating expectations about potential harms. In this sense, the nocebo effect extends beyond individual cognition and becomes embedded within a broader sociocultural context. This has been particularly evident in cases of mass psychogenic illness, where groups of individuals report similar symptoms without an identifiable organic cause, often following exposure to shared information or perceived threats. From a neuroendocrine perspective, the stress response system is a key mediator of nocebo effects. Activation of the hypothalamic, pituitary, adrenal, HPA, axis leads to the release of cortisol and other stress hormones, which can influence immune function, inflammation, and pain sensitivity. Chronic activation of this system, driven by persistent negative expectations, may contribute to long-term health consequences. This highlights the importance of addressing cognitive and emotional factors not only in acute symptom management, but also in the prevention of chronic conditions. Ethical considerations surrounding the nocebo effect are particularly complex. In clinical practice, healthcare providers are obligated to inform patients about potential risks and side effects of treatments. However, the manner in which this information is communicated can significantly influence patient outcomes. Beyond its basic definition, the nocebo effect has become an increasingly important subject in contemporary biomedical research due to its implications for both experimental design and clinical outcomes. One of the central theoretical frameworks used to explain the nocebo phenomenon is predictive coding, a model suggesting that the brain continuously generates predictions about incoming sensory information and updates these predictions based on error signals. Within this framework, negative expectations function as top-down predictions that bias perception toward adverse outcomes. When an individual anticipates pain or discomfort, the brain effectively pre-activates neural pathways associated with those sensations, increasing the likelihood that ambiguous or neutral stimuli will be interpreted as negative. This process illustrates how perception is not a passive reflection of reality, but an active construction shaped by prior beliefs and contextual information. Experimental studies have provided robust evidence supporting this predictive model. In controlled laboratory settings, participants exposed to negative verbal suggestions about a harmless stimulus, such as a mild thermal or tactile input, report significantly higher levels of pain compared to control groups. Importantly, these subjective reports are often accompanied by objective physiological changes, including increased skin conductance, elevated heart rate, and altered hormonal responses indicative of stress activation. Such findings reinforce the notion that nocebo-induced symptoms are grounded in measurable biological processes rather than mere reporting bias. Another critical dimension of the nocebo effect involves learning mechanisms, particularly classical conditioning. Repeated associations between a neutral stimulus and an adverse outcome can condition individuals to experience negative effects even in the absence of the original trigger. Understanding the nocebo effect is therefore essential for improving clinical practice and patient care. Strategies to mitigate nocebo responses include optimizing doctor-patient communication, framing information in a balanced manner, and fostering positive therapeutic relationships. Emerging research also suggests that cognitive and behavioral interventions may help reduce maladaptive expectations and attenuate symptom amplification. Ultimately, the nocebo effect underscores a fundamental principle of human physiology, that the brain does not passively receive information from the body, but actively interprets and shapes bodily experience based on expectations, context, and prior knowledge. Recognizing this dynamic interaction offers valuable insight into the mechanisms of health and disease and highlights the importance of integrating psychological and neurobiological perspectives in modern medicine. From a psychological perspective, the nocebo effect is closely related to mechanisms such as classical conditioning, observational learning, and verbal suggestion. Individuals may develop nocebo responses through prior negative experiences with treatments, exposure to information about potential side effects, or social transmission of expectations. For example, patients informed about the possible adverse effects of medication are statistically more likely to report those symptoms, even when receiving an inert substance. This phenomenon raises important ethical and clinical considerations regarding informed consent and risk communication, as healthcare providers must balance transparency with the potential for expectation-induced harm. Clinically, the nocebo effect has significant implications for treatment adherence, patient outcomes, and the interpretation of side effect profiles in clinical trials. It has been observed across a wide range of conditions, including chronic pain disorders, neurological syndromes, and functional somatic conditions. In randomized controlled trials, adverse events reported in placebo groups are often attributed to nocebo mechanisms, illustrating the powerful role of expectation in shaping symptom perception. Furthermore, individual differences such as personality traits, anxiety sensitivity, and genetic predispositions may influence susceptibility to nocebo responses, suggesting a complex interaction between biological vulnerability and cognitive emotional factors. Sleepy dormitions presents a scientific exploration of the nocebo effect, a psychobiological phenomenon in which negative expectations, prior beliefs, and contextual cues contribute to the onset or amplification of adverse symptoms in the absence of a direct pharmacological or physiological cause. In contrast to the placebo effect, which has been widely studied for its capacity to induce symptom relief through positive expectation, the nocebo effect demonstrates that anticipatory cognitive processes can also generate measurable negative outcomes, including increased pain perception, heightened anxiety, and physiological dysregulation. The nocebo response is not merely a subjective or imagined experience. Rather, it is supported by converging evidence from neuroscience, experimental psychology, and clinical research, indicating that expectation-driven mechanisms can modulate central nervous system activity and peripheral bodily responses. At the neurobiological level, the nocebo effect has been associated with the activation of brain regions involved in pain processing and emotional regulation, including the anterior cingulate cortex, insular cortex, and prefrontal areas. Functional neuroimaging studies have demonstrated that negative expectations can increase activity in these regions, thereby enhancing the subjective experience of pain. Additionally, the nocebo response has been linked to the activation of cholecystokinin, CCK, a neuropeptide known to facilitate pain transmission and anxiety. This contrasts with placebo-induced analgesia, which is often mediated by endogenous opioid and dopamine systems. The interplay between these neurochemical systems highlights the bidirectional influence of cognition on physiological processes. Future research directions in the field of nocebo studies are likely to be interdisciplinary, combining insights from neuroscience, psychology, genetics, sociology, and health communication. Advanced neuroimaging techniques, computational modeling, and machine learning approaches may provide more precise characterization of the neural and behavioral patterns associated with nocebo responses. Additionally, ecological momentary assessment methods, which capture real-time data in naturalistic settings, may offer a more accurate understanding of how nocebo effects unfold in daily life. Another promising avenue involves the integration of digital health technologies. Wearable devices, mobile health applications, and virtual reality platforms can be used both to study and to intervene in expectation-related processes. For example, real-time feedback on physiological states may help individuals reinterpret bodily sensations more accurately, reducing the likelihood of negative misattribution. Similarly, digital interventions designed to modify expectations and reduce anxiety could serve as scalable tools for mitigating nocebo effects in large populations. Ethical considerations will continue to play a central role as the field advances. The increasing ability to predict individual susceptibility to nocebo effects raises questions about how such information should be used in clinical decision-making. Ensuring that predictive tools are applied in a way that benefits patients without stigmatization or discrimination will be essential. Moreover, maintaining transparency while minimizing harm will remain a guiding principle in both research and practice. In conclusion, the nocebo effect represents a complex interplay of biological, psychological, social, and cultural factors that collectively shape human health and illness experience. Its influence extends far beyond the boundaries of controlled experiments, permeating everyday medical practice and societal health dynamics. Genetic and epigenetic factors are emerging as additional layers of complexity in understanding nocebo susceptibility. Variations in genes related to neurotransmitter systems, such as dopamine, serotonin, and opioid pathways, may influence how individuals process expectation and stress. Epigenetic modifications, shaped by environmental exposure and life experiences, may further regulate the expression of these genes, creating dynamic interactions between biology and environment. Although this area of research is still in its early stages, it holds promise for identifying biomarkers associated with nocebo responsiveness. Developmental factors also warrant consideration. Early life experiences, including exposure to illness, parental attitudes toward health, and prior medical encounters, can shape long-term expectations and coping strategies. Individuals who have experienced repeated negative medical outcomes or high levels of health-related anxiety during childhood may develop heightened sensitivity to nocebo effects in adulthood. This developmental perspective emphasizes the importance of longitudinal research in understanding how nocebo susceptibility evolves over time. From a systems-level perspective, healthcare infrastructure and policy can indirectly influence nocebo phenomena. Overemphasis on risk disclosure without adequate contextualization, time constraints in clinical consultations, and fragmented care delivery may all contribute to increased patient uncertainty and negative expectation formation. Conversely, integrated care models that prioritize communication, continuity, and patient engagement may help mitigate these effects. This suggests that addressing the nocebo effect is not solely the responsibility of individual clinicians, but requires systemic approaches at the institutional and policy levels. Genetic and epigenetic factors are emerging as additional layers of complexity in understanding nocebo susceptibility. Variations in genes related to neurotransmitter systems, such as dopamine, serotonin, and opioid pathways, may influence how individuals process expectation and stress. Epigenetic modifications, shaped by environmental exposure and life experiences, may further regulate the expression of these genes, creating dynamic interactions between biology and environment. Although this area of research is still in its early stages, it holds promise for identifying biomarkers associated with nocebo responsiveness. Developmental factors also warrant consideration. Early life experiences, including exposure to illness, parental attitudes toward health, and prior medical encounters, can shape long-term expectations and coping strategies. Individuals who have experienced repeated negative medical outcomes or high levels of health-related anxiety during childhood may develop heightened sensitivity to nocebo effects in adulthood. This developmental perspective emphasizes the importance of longitudinal research in understanding how nocebo susceptibility evolves over time. From a systems-level perspective, healthcare infrastructure and policy can indirectly influence nocebo phenomena. Overemphasis on risk disclosure without adequate contextualization, time constraints in clinical consultations, and fragmented care delivery may all contribute to increased patient uncertainty and negative expectation formation. Conversely, integrated care models that prioritize communication, continuity, and patient engagement may help mitigate these effects. This suggests that addressing the nocebo effect is not solely the responsibility of individual clinicians, but requires systemic approaches at the institutional and policy levels. Societal context, individual differences, future directions. Beyond the confines of laboratory and clinical settings, the nocebo effect operates within a broader societal and cultural framework that significantly shapes its expression and impact. Expectations about health, illness, and treatment are not formed in isolation. Rather, they are embedded within cultural narratives, social norms, and collective beliefs. These contextual influences can modulate both the prevalence and intensity of nocebo responses, highlighting the importance of adopting a cross-cultural perspective in nocebo research. Cultural factors influence how individuals interpret bodily sensations, assign meaning to symptoms, and respond to medical information. In some cultural contexts, heightened attention to bodily signals and greater emphasis on potential harm may increase susceptibility to nocebo effects. Conversely, cultures that promote resilience, trust in medical systems, and positive health beliefs may exhibit reduced nocebo responsiveness. Language itself plays a critical role, as the specific wording used to describe symptoms and risks can alter perception and expectation. This underscores the necessity of culturally sensitive communication strategies in global healthcare practice. Individual differences further contribute to variability in nocebo responses. Personality traits such as anxiety sensitivity, neuroticism, and pessimism have been consistently associated with increased vulnerability to expectation-induced symptoms. Cognitive styles, including attentional bias toward threat and a tendency toward catastrophic interpretation, can amplify the perception of discomfort. Interoceptive accuracy, the ability to detect internal bodily signals, may also play a role, with individuals who are more attuned to subtle physiological changes being more likely to notice and interpret these changes negatively under conditions of expectation. The implications of the nocebo effect extend to public health and health communication on a broader scale. Media reporting on medical treatments, potential side effects, and health risks can significantly shape public expectations and, consequently, population-level symptom patterns. Sensationalized or imbalanced reporting may contribute to widespread nocebo responses, particularly in the context of new or controversial medical interventions. This underscores the need for responsible science communication that accurately conveys risks without unnecessarily inducing fear. In addition, digital environments, including online forums, social media, and health information websites, serve as powerful vectors for the dissemination of expectations. Exposure to anecdotal reports of adverse effects can influence individual perception and increase the likelihood of symptom development. Understanding these dynamics is essential for developing effective strategies to counter misinformation and promote evidence-based health literacy. Ethically, the management of nocebo effects requires a delicate balance between respecting patient autonomy and preventing harm. While withholding information is not acceptable, the selective and thoughtful presentation of information is both permissible and necessary. Concepts such as contextualized informed consent emphasize tailoring communication to the individual patient's needs, preferences, and psychological profile. This personalized approach aligns with broader trends in precision medicine and patient-centered care. Ultimately, integrating knowledge of the nocebo effect into clinical practice necessitates a paradigm shift in how healthcare professionals understand and address patient experience. Symptoms cannot be viewed solely as direct consequences of physiological pathology or pharmacological action. They must also be understood within a cognitive and contextual framework. Recognizing this complexity enables more effective, compassionate. From an intervention perspective, several strategies have been proposed to reduce the impact of nocebo effects in clinical settings. Cognitive behavioral approaches aim to identify and modify maladaptive beliefs and catastrophic thinking patterns that contribute to negative expectations. Psychoeducation, which involves explaining the mechanisms of the nocebo effect to patients, can also be effective in reducing symptom misattribution and anxiety. Interestingly, informing patients about the nocebo phenomenon itself has been shown in some studies to decrease the likelihood of experiencing adverse symptoms, suggesting that awareness can act as a protective factor. Another promising avenue involves the use of expectation management techniques. These include setting realistic but non-threatening expectations about treatment outcomes, emphasizing variability in individual responses, and reinforcing positive aspects of therapy. In some cases, open-label placebo approaches, where patients are explicitly informed that they are receiving an inert substance, have demonstrated beneficial effects, indicating that transparency and expectation can coexist in therapeutic contexts. Pharmacological interventions targeting the neurochemical pathways associated with nocebo responses have also been explored. For example, agents that modulate anxiety or block specific neuropeptides, such as cholecystokinin, CCK, may reduce susceptibility to nocebo-induced symptoms. However, such approaches remain largely experimental and must be evaluated in terms of safety, efficacy, and ethical acceptability. Clinical practice, ethics, and interventions. The translation of nocebo research into clinical practice represents one of the most critical and challenging aspects of this field. While the experimental evidence for nocebo mechanisms is robust, applying this knowledge in real-world healthcare settings requires careful consideration of ethical principles, communication strategies, and patient-centered care. One of the central dilemmas arises from the necessity of informed consent. Healthcare providers are ethically obligated to disclose potential risks and side effects of treatments. Yet such disclosures can inadvertently induce nocebo responses by shaping negative expectations. The manner in which information is communicated plays a decisive role in modulating patient outcomes. Research in medical communication has demonstrated that framing effects, how information is presented rather than what is presented, can significantly influence the likelihood of adverse symptom reporting. For instance, describing a treatment as well tolerated by most patients instead of emphasizing a long list of possible side effects can reduce the incidence of nocebo responses without compromising informational transparency. This approach, often referred to as positive or balanced framing, aims to preserve patient autonomy while minimizing expectation-induced harm. Doctor-patient interaction itself constitutes a powerful contextual factor. Nonverbal cues, tone of voice, perceived empathy, and the overall therapeutic environment can either amplify or attenuate nocebo effects that a clinician who appears uncertain, overly cautious, or alarmist may unintentionally reinforce patient anxiety and negative expectations. Conversely, a confident, empathetic, and supportive communication style can foster trust and reduce anticipatory distress. This highlights the importance of integrating communication training into medical education as a means of mitigating nocebo-related outcomes. The Salience Network, which includes the anterior insula and ACC, is responsible for detecting and prioritizing relevant stimuli, particularly those associated with potential threats. Hyperactivation of this network under negative expectations may lead to an exaggerated focus on bodily sensations. Meanwhile, the default mode network, DMN, associated with self-referential thinking and rumination, may reinforce negative expectations through repetitive cognitive patterns. Dysregulation in the interaction between these networks can create a feedback loop in which attention, expectation, and perception continuously amplify one another. Importantly, these neural and neurochemical processes do not operate in isolation, but are influenced by contextual and individual factors. Prior experiences, cultural beliefs, personality traits, and environmental cues all shape the formation of expectations and the sensitivity of underlying neural systems. This integrative perspective highlights the nocebo effect as a product of complex, multi-level interactions rather than a simple cause and effect relationship. Understanding these mechanisms has significant implications for both clinical practice and therapeutic intervention. By identifying the neural pathways through which negative expectations exert their effects, researchers and clinicians can develop targeted strategies to modulate these processes. Interventions such as cognitive behavioral therapy, expectation management, and even pharmacological modulation of specific neurotransmitter systems may help attenuate nocebo responses. Ultimately, the study of the nocebo effect provides a powerful framework for exploring how the brain constructs bodily experience and how this process can be influenced to improve health outcomes. At the neurochemical level, the balance between pronociceptive and antinociceptive systems is a critical determinant of nocebo responses. One of the most extensively studied mediators is cholecystokinin, CCK, a neuropeptide that facilitates pain transmission and is associated with anxiety and panic responses. Experimental studies have demonstrated that pharmacological blockade of CCK receptors can reduce nocebo-induced hyperalgesia, providing strong evidence for its causal role. Conversely, endogenous opioid systems, which are typically involved in placebo analgesia, appear to be suppressed or less active during nocebo conditions, further tipping the balance toward increased pain perception. Dopaminergic pathways also play a role in expectation processing and motivational salience. Reduced dopaminergic activity in response to negative expectations may contribute to diminished reward processing and increased sensitivity to adverse stimuli. Additionally, serotonergic systems, which are involved in mood regulation and anxiety, may interact with both dopaminergic and CCK-mediated pathways, creating a complex neurochemical network underlying nocebo responses. Another important component is the hypothalamic, pituitary, adrenal, HPA, axis, which links cognitive processes to endocrine and immune function. Activation of the HPA axis in response to negative expectations results in the release of cortisol and other stress-related hormones. These hormonal changes can influence inflammatory pathways, alter pain thresholds, and modulate immune responses. Chronic engagement of this system may contribute to sustained symptomatology, particularly in conditions characterized by persistent pain or fatigue. Recent advances in network neuroscience have further emphasized the role of large-scale brain networks in the nocebo effect. Theoretical integration and conceptual analysis. A deeper conceptual understanding of the nocebo effect requires situating it within a broader network of related psychobiological phenomena. While traditionally examined in contrast to the placebo effect, contemporary research suggests that the nocebo response should not be viewed merely as its negative counterpart, but rather as part of a continuum of expectation-driven modulation of physiological processes. This continuum encompasses a wide range of phenomena, including stress responses, anxiety-related somatization, and certain forms of functional disorders, all of which share common underlying mechanisms involving predictive processing and cognitive emotional integration. One of the most influential theoretical approaches in this domain is the predictive processing framework, which conceptualizes the brain as a hierarchical inference machine. Within this model, perception is generated through the interaction of top-down predictions and bottom-up sensory input. The nocebo effect can be understood as a case in which high-level negative predictions exert a dominant influence, effectively overriding or biasing incoming sensory signals. This imbalance between prediction and sensory evidence may result in persistent perception of symptoms even when objective physiological indicators are minimal or absent. Closely related to predictive processing is the concept of interoceptive inference, which focuses specifically on how the brain interprets internal bodily signals. According to this perspective, the brain continuously generates predictions about internal states such as pain, fatigue, or discomfort, and updates these predictions based on incoming interoceptive data. In the context of the nocebo effect, negative expectations may increase the precision or perceived reliability of predicted adverse states, leading to heightened sensitivity to bodily fluctuations. This can create a self-reinforcing loop in which expectation The nocebo effect also shares important features with stress-related and anxiety-mediated processes. Activation of threat detection systems, including the amygdala and associated limbic structures, can enhance vigilance toward potential harm and bias attention toward negative stimuli. This heightened state of alertness may increase the likelihood that benign bodily sensations are interpreted as threatening or pathological. In this sense, the nocebo effect can be viewed as an extension of adaptive survival mechanisms that, under certain conditions, become maladaptive. Another relevant comparison can be made with functional somatic syndromes, such as irritable bowel syndrome, fibromyalgia, and chronic fatigue syndrome. Although these conditions are multifactorial and not reducible to expectation alone, they often involve heightened symptom perception, altered central processing, and strong interactions between psychological and physiological factors. The nocebo effect may contribute to symptom exacerbation in these disorders by amplifying negative expectations and reinforcing maladaptive perceptual patterns. Importantly, the distinction between nocebo effects and other forms of symptom generation is not always clear-cut. Overlapping mechanisms, including conditioning, expectation, emotional regulation, and neuroendocrine activation, suggest that these phenomena exist along a spectrum rather than as discrete categories. This perspective challenges reductionist models and supports a more integrative approach to understanding human health. From a conceptual standpoint, the nocebo effect raises fundamental questions about the nature of perception, causality, and embodiment. If expectations can generate measurable physiological changes, then the boundary between mental and physical causation becomes increasingly blurred. Rather than viewing the mind as a separate or secondary influence, it becomes necessary to recognize cognition as an intrinsic component of physiological regulation. This shift in perspective has important implications for both research and clinical practice. It suggests that interventions targeting cognitive and emotional processes are not merely adjunctive, but may be central to the treatment of many conditions. It also highlights the need for more precise, conceptual frameworks that can accommodate the complex interactions observed in nocebo phenomena. In advancing this field, it will be essential to refine theoretical models that integrate multiple levels of analysis, from molecular and neural mechanisms to psychological processes and social context. Such models must account for both the generation and modulation of nocebo responses, as well as their variability across individuals and situations. Achieving this level of integration represents a major challenge, but also a significant opportunity for progress in understanding the mind-body relationship. Experimental paradigms and methodological considerations. A rigorous investigation of the nocebo effect necessitates the use of well-controlled experimental paradigms that can isolate expectation-driven processes from pharmacological and physiological variables. Over the past decades, researchers have developed a variety of methodological approaches to systematically induce and measure nocebo responses under laboratory conditions. These paradigms differ in their degree of ecological validity, experimental control, and susceptibility to bias. Yet collectively, they provide a robust framework for understanding the mechanisms underlying nocebo phenomena. One of the most widely used paradigms involves verbal suggestion, in which participants are explicitly informed that a given stimulus or intervention may produce adverse effects. This approach allows for precise manipulation of expectation while maintaining experimental control. For example, participants may be told that a harmless electrical or thermal stimulus is likely to become increasingly painful over time. Consistently, such instructions lead to elevated pain ratings, even when the intensity of the stimulus remains constant. The strength of this paradigm lies in its simplicity and reproducibility. However, it may not fully capture the complexity of real-world clinical interactions. Conditioning-based paradigms represent another important methodological approach. In these designs, a neutral stimulus is repeatedly paired with an aversive outcome, leading to the formation of learned associations. Once conditioning is established, The neutral stimulus alone can elicit negative responses, even in the absence of the original aversive input. These paradigms are particularly valuable for investigating implicit learning mechanisms and for modeling how prior experiences contribute to nocebo responses. However, distinguishing between conditioned responses and expectation-driven effects can be challenging, as the two processes often interact. Open-hidden paradigms provide a unique method for disentangling the effects of expectation from the pharmacological action of a treatment. In these studies, the same intervention is administered either openly, with the participants' awareness, or covertly, without their knowledge. Differences in outcomes between these conditions are attributed to expectation-related processes. Findings from such studies have consistently demonstrated that both therapeutic and adverse effects are significantly modulated by awareness and expectation, underscoring the importance of contextual factors in medical interventions. Measurement of nocebo responses presents its own set of methodological challenges. Subjective reports, such as pain ratings or symptom questionnaires, are commonly used but may be influenced by reporting biases and individual differences in perception. To address this limitation, researchers often incorporate objective physiological measures, including autonomic nervous system activity, e.g., heart rate, skin conductance, neuroendocrine markers, e.g., cortisol levels, and neuroimaging data. Combining subjective and objective measures allows for a more comprehensive assessment of nocebo effects, though it also increases the complexity of data interpretation. Another critical issue concerns the reproducibility and generalizability of experimental findings. While laboratory studies offer high levels of control, they may lack ecological validity, as real-world clinical environments involve more complex and dynamic interactions. Factors such as long-term treatment exposure, patient history, and social context are difficult to replicate in controlled settings. This raises important questions about how well experimental models capture the full scope of nocebo phenomena in everyday healthcare. Bias and expectancy effects on the part of both participants and researchers must also be considered. Demand characteristics, in which participants adjust their responses based on perceived experimental expectations, can influence outcomes. Similarly, experimenter bias, whether conscious or unconscious, may affect how information is presented or how data are interpreted. Double-blind designs and standardized protocols are essential for minimizing these influences, yet they cannot entirely eliminate them. Ethical constraints further complicate experimental research on the nocebo effect. Inducing negative symptoms in participants raises concerns about potential harm, particularly in vulnerable populations. Researchers must carefully balance the scientific value of their studies against the ethical obligation to minimize distress. This often limits the intensity and duration of induced nocebo responses, which in turn may restrict the ability to study more severe or chronic manifestations. Recent methodological innovations aim to address some of these limitations. Advances in computational modeling allow researchers to quantify expectation-related processes and simulate their effects on perception and behavior. Machine learning techniques can identify patterns in large data sets, potentially revealing subtle predictors of nocebo susceptibility. Additionally, real-time data collection methods, such as ecological momentary assessment, enable the study of nocebo effects in naturalistic environments, providing greater ecological validity. Despite these advances, significant challenges remain. Integrating findings across different methodologies, populations, and contexts requires careful consideration of underlying assumptions and potential sources of variability. Establishing standardized definitions and measurement criteria for nocebo effects is an ongoing effort within the research community. As research continues to evolve, the implications of the nocebo effect extend far beyond controlled experiments. In clinical practice, it emphasizes the critical role of communication, trust, and therapeutic context. In public health, it highlights the power of information and narrative in shaping collective health outcomes. In scientific inquiry, it invites deeper investigation into the mechanisms through which cognition and physiology interact. Across all these domains, a consistent theme emerges: that expectation is not a peripheral factor, but a central determinant of human experience. Sleepy dormitions presents this knowledge not as a source of concern, but as a framework for understanding. The same mechanisms that can amplify discomfort under negative expectations also hold the potential to reduce it under more adaptive conditions. By recognizing the role of expectation, individuals and practitioners alike can begin to engage with these processes more consciously, shaping environments and interactions in ways that support well-being rather than undermine it. In this sense, the nocebo effect is not only a subject of scientific investigation, but also a reminder of the brain's remarkable capacity to influence the body. It invites a shift in perspective, from viewing symptoms as isolated events to understanding them as part of a larger system of interpretation and regulation. And it underscores a broader principle that extends across the study of mind and body. That knowledge, when carefully applied, has the power not only to explain experience, but to transform it. Sleepy Dormitions thanks you for engaging with this exploration. Sleepy Dormitions concludes this comprehensive exploration of the nocebo effect by returning to a central scientific insight: that human experience of the body is not a passive reflection of biological processes, but construction shaped by expectation, context, and prior knowledge. Throughout this discussion, the nocebo effect has emerged not as an anomaly or a marginal curiosity, but as a fundamental expression of how the brain interprets, predicts, and regulates bodily states. The convergence of evidence from neuroscience, psychology, and clinical research has demonstrated that negative expectations can produce measurable, reproducible, and biologically grounded changes in perception, physiology, and behavior. From the activation of specific neural circuits to the modulation of neurochemical pathways, from the influence of verbal suggestion to the impact of social and cultural context, the nocebo effect illustrates the profound interconnectedness of mind and body. It reveals that perception is inherently inferential, that sensation is filtered through belief, and that health outcomes are shaped not only by external interventions, but also by internal cognitive frameworks. This understanding challenges reductionist models of medicine and calls for a more integrative approach, one that recognizes the patient not merely as a biological system, but as a complex, meaning-making organism embedded in a dynamic environment. Importantly, the scientific study of the nocebo effect does not diminish the reality of symptoms. Rather, it deepens our understanding of their origins. The physiological correlates of nocebo responses, ranging from altered brain activity to endocrine and autonomic changes, underscore that expectation-driven effects are not imaginary, but embodied. This distinction is essential for both ethical and clinical reasons, as it reframes patient experience in a way that is both scientifically accurate and respectful of subjective reality. Sleepy Dormitions concludes this comprehensive exploration of the nocebo effect by returning to a central scientific insight: that human experience of the body is not a passive reflection of biological processes, but construction shaped by expectation, context, and prior knowledge. Throughout this discussion, the nocebo effect has emerged not as an anomaly or a marginal curiosity, but as a fundamental expression of how the brain interprets, predicts, and regulates bodily states. The convergence of evidence from neuroscience, psychology, and clinical research has demonstrated that negative expectations can produce measurable, reproducible, and biologically grounded changes in perception, physiology, and behavior. From the activation of specific neural circuits to the modulation of neurochemical pathways, from the influence of verbal suggestion to the impact of social and cultural context, the nocebo effect illustrates the profound interconnectedness of mind and body. It reveals that perception is inherently inferential, that sensation is filtered through belief, and that health outcomes are shaped not only by external interventions, but also by internal cognitive frameworks. This understanding challenges reductionist models of medicine and calls for a more integrative approach, one that recognizes the patient not merely as a biological system, but as a complex, meaning-making organism embedded in a dynamic environment. Importantly, the scientific study of the nocebo effect does not diminish the reality of symptoms. Rather, it deepens our understanding of their origins. The physiological correlates of nocebo responses, ranging from altered brain activity to endocrine and autonomic changes, underscore that expectation-driven effects are not imaginary, but embodied. This distinction is essential for both ethical and clinical reasons, as it reframes patient experience in a way that is both scientifically accurate and respectful of subjective reality. Looking forward, the continued advancement of this field will depend on interdisciplinary collaboration and methodological innovation. Bridging the gap between laboratory findings and real-world applications remains a key challenge. Future research must also address underexplored areas, including long-term nocebo effects, interactions with chronic disease processes, and the role of emerging technologies in both amplifying and mitigating expectation-related phenomena. In conclusion, the nocebo effect represents a fundamental aspect of human physiology and psychology, revealing the profound influence of expectation on health and disease. It serves as a powerful reminder that the mind and body are not separate entities, but components of an integrated system in which perception, belief, and biology are in constant interaction. By acknowledging and understanding this interaction, modern medicine can move toward more effective, ethical, and patient-centered approaches to care. The study of the nocebo effect is therefore not merely an exploration of a specific phenomenon, but a window into the deeper mechanisms that shape human experience itself. At the same time, the nocebo effect should not be interpreted as implying that symptoms are imaginary or under voluntary control. Final sections, discussion and conclusion. The cumulative body of research on the nocebo effect provides compelling evidence that human perception of health and illness cannot be fully understood through purely biomedical models. Instead, the nocebo phenomenon illustrates the necessity of a biopsychosocial framework in which cognitive expectations, emotional states, social context, and neurobiological processes are dynamically intertwined. This integrative perspective challenges traditional distinctions between real and psychological symptoms, demonstrating that expectation-driven experiences are grounded in measurable physiological mechanisms. One of the most significant implications of this body of work is the recognition that medical interventions are never context-neutral. Every treatment is embedded within a network of meanings, beliefs, and expectations that influence its outcome. The same pharmacological agent may produce different effects depending on how it is presented, what the patient anticipates, and the broader therapeutic environment. In this sense, the nocebo effect is not an anomaly, but a fundamental component of all medical interactions. The evidence reviewed across experimental, clinical, and neuroscientific domains converges on a central principle. The brain actively constructs bodily experience through predictive and interpretive processes. Negative expectations act as powerful modulators of this construction, shaping perception in ways that can lead to genuine suffering. Importantly, these processes operate largely outside of conscious awareness, making them difficult to control through simple rational reasoning. This underscores the importance of addressing expectation at both conscious and implicit levels in clinical practice.